But yeah, essentially I do sleep medicine here at Etobicoke, and then one day a week I see kids and do sleep as well there. I'm going to talk about high flow and I guess the pros, the cons, the challenges of that in pediatric OSA. And this presentation we kind of presented last year at the summer grand rounds at SickKids, and so I just wanted to credit my co-fellow then, Dr. Natalia Escobar, for helping put together some of these slides as well. I don't have any conflicts of interest. We're going to go through case introduction. I just have one case, and then a little bit about pediatric OSA, but Sunny Bola has already kind of gone through most of that, so we'll fly through that. Hopefully gets us to lunch earlier. The management of OSA, some pearls on high flow nasal cannula, but also some words on the challenges and the future direction for high flow therapy, as well as wrapping up the case and hopefully give you some conclusion points to take away. The learning objectives here is to review OSA presentation, pathophysiology very briefly, because it's already been discussed before. The treatments as well, we'll talk about very briefly, and then to explore the use of high flow nasal cannula in pediatric OSA, including the advantages and disadvantages, and that's what we'll pay most attention on. And then also closing in with some current challenges that we face when using high flow nasal cannula out of the hospital. So my first case is a child with trisomy 21 who is obese. They were initially seen at 2 years of age, and they were referred for suspected OSA. They had a history of snoring, frequent apneas, enuresis nocturnally, as well as sweating overnight. And he was sleeping in the prone position. His initial sleep study had shown severe obstructive sleep apnea with an OHI of 62 events per hour, which is very severe, and it was associated with hypoventilation as well, and went down into severe DSATs with an oxygen saturation of 31%. And that's just his weight curve there. So what would you do next? Reassurance, as this will likely improve with time. Reassure for now and repeat sleep study 1 month. Consult otolaryngology for consideration of surgery, or admit to pediatric medicine, because that's always right. So as we know, we should consult ENT because adenotonsillectomy is first-line treatment in children. And so this child underwent adenotonsillectomy. It was a little bit complicated because he did require PICU admission post-surgery due to pulmonary edema and persistent obstructive sleep apnea. He was started on CPAP. The post-surgery sleep study still showed the obstructive sleep apnea to be in the severe range, which was corrected with CPAP therapy. And so he eventually went home with a nasal mask, but lo and behold, did not tolerate the mask. And as you can see in the report there in the figure, he was only using it for less than 2 hours, and that was only really just on 2 days. And so he underwent a review to consider further surgical intervention, and so he underwent revision adenoidectomy as well as bilateral inferior turbinate reduction in 2023, but he continued with same sleep symptoms. Okay, so this is his repeat sleep study. In the top portion is your hypnogram. So you can see that he's having quite fragmented sleep. For those unfamiliar with this hypnogram, essentially the red lines are showing REM sleep, the blue lines are showing when he's awake, and all the other lines are showing different stages of sleep. And you can see that he seems to be having quite disrupted sleep with frequent arousals and awakenings throughout the night. The middle portion here is just showing us where the events are mostly happening. And so you can see that they seem to be clustered around REM areas. And they're mostly taking off here, which is the obstructive apneas and the obstructive hypopneas, and there is associated desaturations. The bottom portion here is an oximetry, and you can see that there seems to be still moderate to severe oxygen desaturations that are mostly centered around REM periods. So what he underwent next was a high flow nasal cannula titration study. And so very similar setup to what I showed before, but we have an additional piece here. This is the titration of his high flow nasal cannula. Began just around, I think, 2 liters per minute and went up to 20 liters per minute. And what I'm hoping you could see here is that there seems to be less disrupted sleep, so less awakenings and arousals overnight, less obstructive events. And you can see that his oximetry shows significant improvement, especially when titrated up to the final setting of 20 liters per minute. This is just a comparison between the 2 oximetries that you see, and we have permission to show pictures. And so this child was feeling much more comfortable while on high flow nasal cannula. So I'm going to go through this very quickly. All right. So I think Sunnybull has already kind of gone through this very well, and so we'll go through this quick. But essentially, obstructive sleep apnea is where you get partial or complete airflow limitation that results in gas exchange abnormalities. It can lead to arousals. Can occur up to 5% of children. The risk factors we talked about earlier, but especially those with obesity, craniofacial abnormalities, neuromuscular weakness, and children with medical complexity. The pathophysiology, again, Dr. Bull has kind of gone through this, but the way I think about it is there's 4 different areas. It could be upper airway anatomy, as explained earlier, most common cause being adenotonsillar hypertrophy, and that's basically has to do with reduced volume in the upper airway. Could be due to neuromuscular control, where you have this weakness and it results in increased airway collapsibility, and that's where the peak pressure comes in. And then Dr. Durang will talk about these later, but the stability of ventilatory drive, where you have an exaggerated looping and a low arousal threshold, can also be resulting in obstructive sleep apnea. Symptoms we went through before, but I think about them as well in the daytime and nighttime. And then why does it matter? As Dr. Bola says, it basically affects all aspects of a child's life, including neurobehavioral, overlaps significantly with ADHD, and can cause issues with executive function and developmental delay. Metabolic has to do with the activation of your sympathetic nervous system, which can lead to insulin resistance. And similarly, that increased activation of your sympathetic nervous system can result in cardiovascular issues, including systemic and pulmonary hypertension, and can have effects on your psychosocial function as well. So affects everything. The evaluation, as Dr. Bull has already gone through, there's screening questionnaires and overnight oximetries, which all have limited use. And always important to note that in a normal overnight oximetry, although reassuring, cannot rule out sleep disordered breathing. And so the gold standard overnight sleep study.
Price. Yeah.
And maybe someone should mute themselves. Yeah. Okay, this is what a sleep study looks like. Further development. So this is what a sleep study looks like. Again, it's a gold standard. The issues, though, are the long wait times, given how resource intensive it is, and the different leads that go into it include the EEG leads, ECG, EMG leads. We use sensors over the nose and the mouth to look at airflow coming in and out, and then belts that go over the chest and the belly to see how the chest and belly move when they're asleep, oximeters, and then measurements for end-tidal hole and sometimes transcutaneous CO2. The management, as Dr. Bull has gone through, the adenotonsillectomy remains first line, but there are children who are at increased risk of persistent OSA, which we've already talked about. This is just a nice study that kind of looks at that in a bit more detail when it comes to the obese population being at risk for persistent OSA. So this is a study, I think, from 2007, where they looked at 72 kids, including 33 of them being obese and 39 being normal weight. And so what I'm hoping you can see is that in children who are obese, a significant portion had severe obstructive sleep apnea. And then when they underwent adenotonsillectomy, only about a quarter had complete resolution of their obstructive sleep apnea, and the other 3/4 had persistent OSA, and 15% remained severe. This is very different from children who are normal weight per se, who, after they undergo adenotonsillectomy, it's a complete opposite, where almost 3/4 actually have complete resolution of their obstructive sleep apnea, and only about a quarter remain to have some element of OSA, including none with severe obstructive sleep apnea. This is a very similar talk slide, so we're going to skip that. So CPAP usually remains first line non-surgical option when patients are diagnosed with moderate to severe obstructive sleep apnea, especially if they have continued OSA after ENT surgery, or if there's no amenable site to address, or they prefer not to go through surgery. And so how it works is basically it alleviates the upper airway obstruction. You're essentially stenting the airway, and the respiratory effort is entirely patient dependent. So that airway stenting increases your intraluminal pressure, and therefore you're trying to get above that critical transluminal pressure, preventing your airway collapse. The adherence, though, is the big problem, as we discussed through the audience interaction earlier. That this is one of the bigger challenges, especially in the pediatric group. There's really no standard definition for what adherence in pediatric patients mean. In adults, I think the number that they use is the usage of CPAP greater than 4 hours per night. But as we can imagine, children sleep much longer, different sleep patterns, and so using that same definition in pediatrics is not always so relevant. BiPAP is different than CPAP because you're cycling pressures with inspiration and expiration. And so essentially you're delivering cycling preset pressures that's higher during inspiration and lower during expiration. And you're trying to use this when you have cases of significant hypoventilation or central sleep apnea as well that can be associated with obstructive sleep apnea. But as we've seen before, CPAP could still be helpful in those cases, such as the case where Dr. Bola talked about. The challenges, again, have to do with the use of the machine, caregiver buy-in. You obviously have some effects that can happen with skin breakdown, eye irritation, discomfort, and obviously cost being a barrier as well. So what are some other treatment options? We kind of gone through this earlier, but you have adenotonsillectomy. We talked about CPAP, BiPAP, and then there's other options like intranasal steroids, LTRAs, like Sunny mentioned with Montelukast, alternative surgeries that are guided by Dyson, and the MRI, as he mentioned, bariatric surgery, not so commonly done in pediatrics, orthodontic treatments, as was mentioned earlier, is very, very helpful, and then hypoglossal nerve stimulation, where you implant a device that stimulates the nerve under the tongue to prevent collapse. But where does high flow therapy come into play here? And so what is high flow therapy? High flow therapy is basically, it's a device that provides high flow and warmed air or oxygen, and it's delivered primarily with a soft nasal cannula through an open circuit, although there are other interface options available. And depending on the size of the cannulas, can provide up to 60 liters per minute. The more common model that we see is a MyAirbo 2, although there is a MyAirbo 3 now as well. This is kind of what the setup looks like. The mechanism is very important when we think about why high flow could be beneficial in pediatric patients. So firstly, how does it work? So the first mechanism is that it does generate positive airway pressure. And so this is by basically providing expiratory resistance. And while you're breathing against this high inspiratory flows, it does help to prevent airway collapse. The flow rates that are required to generate sufficient pressure is, although dependent on the size of the patient, the pharyngeal length, sometimes their body habitus as well, and it can improve alveolar ventilation. And I think the thoughts now are that it can deliver up to 4 to 7 centimeters of water when you're at reaching maximum flow rates. The other mechanism is that it does prevent or actually reduce anatomic dead space by helping facilitate CO2 washout. And the way that it does is it increases your end expiratory lung volume. So that causes caudal retraction of the pharyngeal airway, and that leads to reduced upper airway collapse, improves lung volumes, and nasopharyngeal dead space washout, which can all improve gas exchange. And so that's kind of the beneficial point of it. And this is what you're seeing in this slide, which represents clearance of a radioactive tracer. And so as you can see from control versus the increasing flow rates, as the flow rate increases, you're getting better and better clearance of the expired air in the upper airways. And that can reduce rebreathing of gas with high CO2 and depleted oxygen, and therefore improves your alveolar ventilation. Other mechanisms of why high flow therapy might be beneficial is that the delivery of heated and humidified air to the nasopharynx at higher than usual flow rates can actually activate the protective airway reflexes through the nasopharyngeal mechanoreceptors and the thermoreceptors. When it exceeds the inspiratory demands of the patient, it can actually help to decrease the work of breathing as well, and it helps to improve mucociliary clearance as well. And the way it does this is that humidity hydrates your mucus-lined airways and allows for better secretion, clearance, and management. Pros and cons time. So in terms of the pros, I mean, obviously there is some comfort and tolerance with this. It's less invasive. It's more comfortable for PAP than PAP therapy. It could be used as an alternative for persistent OSA, especially children who are non-adherent or intolerant to CPAP therapy, or those who are younger, as we discussed earlier. It could be a challenge in young infants using CPAP. There's less risk of GERD, gastroesophageal reflux disease, and aspiration. And in some populations, such as those with like craniofacial anomalies, where we may have resorted to tracheostomy, this may be a kind of a buyout measure where you can try and avoid the insertion of a tracheostomy. The cons are also big, though. So it's not portable. So as you can imagine, this can have significant impacts on the functioning day-to-day of a child and their family. There's so far no built-in capacity, unlike CPAP and BiPAP devices, to monitor adherence and efficacy with downloads, although I think that's being worked on. And similarly, there's no alarms in case of displacement accidentally during the night. It also does not provide real-time monitoring of your generated flow. And the bigger issue here right now is ongoing costs, because currently, as it stands, it's not fully covered by health insurance in Canada and the USA. Although there are some exciting updates coming that hopefully we could share in the future. In terms of contraindications, as with everything, we can break this down into relative and absolute contraindications. And these are pretty similar to what we see with PAP therapy. And so in both acute and chronic use, the absolute indications would include having an unstable airway, respiratory arrest, basal skull fractures with CSF leaks, tracheoesophageal tears. And then the relative contraindications include those with pneumothorax, pneumomediastinum, having central sleep apnea, significant reflux, or if you're already concerned for being fluid overloaded. And so just practically, how do we initiate high flow therapy? Well, the first step really is to select the appropriate size cannula. And you want to basically ensure that the cannula that you're using doesn't include more than 50% of the nares. So that's what that figure is trying to show. It can be initiated either during an in-hospital admission for the child prior to discharge, or you could do this in an outpatient setting if it's done in the sleep lab with a high-flow nasal cannula titration. But whenever it is initiated, monitoring should include not only respiratory events, but also assessing for central emergent events and CO2 levels. In terms of like the pressures or the flow rates, I should say, to start with, there's really no consensus on this. And so it can range anywhere between 5 to 10 liters per minute, unlike in acute settings where you base it on your weight. So like 1 to 2 liters per kilogram is what we usually see. There's really no consensus in the outpatient setting when it's being used for sleep disorder breathing. It also depends if you're using a pediatric cannula or an adult cannula. So pediatric cannulas generally allow you to go up to 25 liters per minute, and then the adult cannulas will allow you to go up to 60 liters per minute. In terms of follow-up, as we mentioned, use of high-flow nasal cannula currently doesn't allow for monitoring with downloads, and so you generally get by with more close clinical follow-ups, typically every 3 months or so, and then maybe considering PSG repeats on an annual basis or sooner if needed. So regarding efficacy of using high-flow therapy, the objective in this study that we'll talk about was to look at the efficacy in infants who have moderate to severe obstructive sleep apnea. And so this was a retrospective study from March 2014 to August 2017. And they include infants who were diagnosed with moderate to severe obstructive sleep apnea. The OHI in these patients was quite variable, ranging from 5 to about 89 events per hour. These infants were recommended for high-flow therapy due to having residual OSA after surgery, or having a prior intolerance of CPAP, or refused CPAP from the family, and being otherwise poor surgical candidates as well. And so, although the N is small, it's only 22 patients with a mean age of just over a year. And what I'm hoping you can see here is that when you're comparing the obstructive apnea-hypopnea index at baseline, mean OH in these patients was around 29 events, and that decreased significantly down to about 3 events per hour with high-flow therapy. So you can see that it does seem to help and shows the efficacy of high-flow therapy in this group. Here's another study where basically it's a single-blinded randomized control trial. Some of the names we'll recognize from the author list here, but they wanted to look at the efficacy of high-flow nasal cannula therapy compared to CPAP in the management of OSA in children who have medical complexity as well. And this was done at sick kids over a 2-year period from 2019 to 2021, where they included pediatric patients above 2 years of age who have moderate to severe OSA. N is again small in these patients, unfortunately, about 18 patients included, older group now, so you're looking at a mean age of 12 years of age. And basically what they did is each child underwent a baseline sleep study, and then they completed 2 further sleep studies, a high-flow nasal cannula titration study and a CPAP titration study in a 1-to-1 randomized allocation order. And then these children had then the opposite CPAP or high-flow titration study as well. The high-flow titration study usually started at 5 liters per minute and went up in 5-liter increments if using pediatric cannulas. If they use adult cannulas in larger patients, then they start at 10 liters per minute and went up in 10-liter increments as well. And then in CPAP, they started at 4 centimeters of water and they went up usually 1 to 2 centimeter increments. The primary outcome was to compare the efficacy of high-flow nasal cannula compared to CPAP to treat moderate to severe OSA in these patients. And their secondary outcome was to compare other sleep parameters such as sleep efficiency, oxygen saturation nadir, arousal index, saturation index. And so similar to the other study, you can see here that there's really no significant difference, or actually even I should back up and say, as you can see, the high-flow nasal cannula and CPAP therapy, they both seem to improve the OHI from baseline. And then this chart here is showing the reduction in the OHI between high-flow nasal cannula and CPAP. And so you can see they both reduced it by around negative 20 almost events per hour, but there is no significant difference between high-flow and nasal cannula. So they're equally efficacious in doing this job. In terms of their secondary outcomes, which was to look at things like oxygen status, arousal index, desaturation index, again, there's really no difference. So both high-flow nasal cannula and CPAP did increase your mean oxygen saturation nadir and decrease your arousal index, and there was really no difference between high-flow nasal cannula or CPAP in either of these. So the discussion from that slide was really that high-flow nasal cannula and CPAP, they provide similar improvements in terms of OSA severity, especially in children who are at risk of having persistent OSA, such as those with obesity and underlying medical complexity. And so it remains a promising option for these patients, such as those that are intolerant to CPAP therapy, those that don't have proper fitting CPAP interfaces, those with secretion management, and those that are unwilling to trial other options. Okay, so this is a different study here. This was done in 1 year from January to December of 2016. They looked at patients from 0 to 18 years of age who had severe OSA, and they were treated with CPAP. But these patients were really not compliant with CPAP. And so what we mean by that is they all had less than 2 hours per night of usage over a 4-week interval. And they wanted to see here, could the adherence be improved if they were switched to high-flow nasal cannula instead? Again, small n, so that's a common theme here, but it kind of highlights the new emerging technology here and why we don't have large studies. But this is a prospective study of about 8 patients who all had some underlying complexity. So as you can see here, 5 of the 8 here had, or even 6 of the 8 actually had Down syndrome. 1 had Pfeiffer syndrome, 1 had Pierre-Robin syndrome as well. And so they basically were using CPAP and non-compliant, and then they were switched to high flow with the Airvo, and we're looking at 1 month compliance afterwards to see if there was any improvement. And so what I'm hoping I can show you from here is that in 5 of those 8 patients, the mean adherence was 7 hours and 10 minutes. So that's significantly improved from less than 2 hours that they were having with CPAP therapy. You can see that it is efficacious because the average AHI decreased from 36 down to 2 events per hour. So it's working and they're compliant with it. Now, 3 of the 5 still did remain non-compliant, but it was a significant improvement compared to CPAP. I guess we have time for this. Okay, so this is a second case of monozygotic twins, again with underlying complexity with craniofacial abnormalities, skull shape, they have microphthalmia, cataracts, micronaphia, and short stature. They also had another upper airway issue where they had a piriform aperture stenosis, which is basically a narrowed upper nasal passages, and they were referred to sleep clinic due to concerns for sleep disorder breathing. And so they underwent a baseline sleep study in 2013, which showed severe obstructive sleep apnea. But since they were not considered surgical candidates and no CPAP interfaces were really suited for their facial anatomy, ENT had recommended a tracheostomy at the time. But what we actually did here is we did a sleep study with high-flow nasal cannula titration, and it seemed to completely correct their severe obstructive sleep apnea. And so we were able to successfully avoid the use and insertion of a tracheostomy tube in these twins, which is great. And so what is the experience with high-flow nasal cannula at our institution? And so at SickKids, basically, the indications for using this, I mean, it's not very well published right now. And so this slide I got from my mentor, Dr. Amin. But basically, the indication right now is to provide respiratory support, and that could include children with sleep disorder breathing, those who have underlying chronic lung disease of prematurity or increased work of breathing, those that have chronic respiratory insufficiency, those that need help with secretion clearance, such as those with tracheostomy as well. If we need to provide higher FiO2 in certain patients that have refractory hypoxemia, such as end-stage lung disease, and that kind of ties into palliative care as well. And so just to, I guess, hone in on this a little bit more, what we're trying to show in this slide is that the use of high-flow therapy seems to be increasing over time. So it is becoming an emergent treatment option. And so this is data from SickKids where they want us to describe patient characteristics, indications, and outcomes of children who are on high-flow nasal cannula therapy at home. 35 children were included. Youngest age was 6 months all the way up to 14 years of age. And so what I'm hoping you can see from this chart is that, yeah, we're starting to use more and more high-flow nasal cannula therapy over time. And I think that this is from 21, 22, but these numbers are going to be much higher now as well. The primary indications for what high-flow therapy is being used for at SickKids would be upper airway obstruction, kind of ties into sleep disorder breathing there, clearance of CO2 in a lot of those patients as well, increased work of breathing, and then secretion management. So now to kind of talk about some of the challenges. So firstly, it's the funding piece is a big issue here, and that's what I want to finish off with. So currently, the ADP, the Assisted Devices Program, covers the cost of specialized equipment, and that includes things like CPAP, BiPAP, tracheostomy, cough assist, oximeter monitoring, and ventilators. And unfortunately, high-flow nasal cannula therapy currently is not covered. And so what is the cost of using Airvo or high-flow therapy at home? And so this is an estimate from Medigas. Usually you get two options. You can either buy the device upfront and then pay for disposables, or you can rent the device and then pay for disposables as well. So I'll show you the two numbers here. And in terms of the different options, there are two other water chamber options you can get. You can get one that has a reusable water chamber and one that has an autofill water chamber. The reusable water chamber is a bit more affordable, but then families may need to refill the chambers overnight, and so that's the reason why you're paying for the convenience of the autofill. But let's say if you were to purchase up front, usually the cost is somewhere between $3,000 to $4,000, which is not insignificant, and then the disposables can cost up to $300 per month. And so you may ask, what the heck are the disposables? The disposables are basically the prongs that they come with and some of the tubing that you'll need to change as well. If you're renting, then depending on the model, it could be between $750 to about $1,800, and then you pay another rental fee for Airvo for $275, and then $300 per month afterwards. And so, as you can imagine, this kind of begs the question of patient advocacy. So we definitely need to advocate for this more. I think an application has currently been submitted to Health Quality Ontario panel, and is advancing through the steps for that. And the idea is hopefully we might be able to also advocate for better insurance coverage for families. Depending on the family's insurance providers, sometimes we do have success in getting coverage for high-flow nasal cannula therapy at home, but as Sunny will tell you, it's a challenge and delays hospital discharge. So this is a slide from Dr. Narung's talk, but basically I'm hoping that through the couple of talks that we've had so far, we've talked about the pathophysiology and the risk factors for having sleep disorder breathing and persistent obstructive sleep apnea after surgery. We talked about the different options, including surgery, pharmacotherapy with nasal steroids. We talked about CPAP, BiPAP. We talked about the surgical interventions and then some therapies beyond that, including high-flow nasal cannula. Future directions. So what we're hoping to see is a larger RCT study looking at high-flow nasal cannula versus CPAP at home. And I think Ingrid Narung is leading some of that. Better understanding of the long-term effects of using high-flow nasal cannula in pediatric OSA specifically, outside of the acute setting, and then ongoing advocacy for high-flow nasal cannula funding in Ontario. I want to conclude by saying high-flow nasal cannula is a promising therapy for pediatric OSA. It's efficacious in the different mechanisms that we talked about, such as providing positive airway pressure therapy, such as reducing your anatomic dead space, and for improving CO2 washout. Advocacy efforts are very, very important, and I'm happy to say a large portion of that's currently underway for getting high-flow nasal cannula therapy covered at home. And the current challenges, such as the funding piece, should be considered by clinicians when we're discussing which patients should be offered high-flow nasal cannula therapy for OSA at home. And that's pretty much it. That's where I would like to kind of finish off.
Question? So, for the population for them to have a sleep study done, do they come for 20, like for overnight study, and do they come here to sleep alone, or do they have to have a parent with them for overnight study as well?
Yeah, I guess the questions around the logistics and the involvement of caregivers for pediatric studies. So generally what we do is we do sleep studies overnight, typically from, let's say, 8 p.m. to around 6 in the morning. And then for all children under 18 years of age, we usually request at least one caregiver overnight to stay in the same room as them the entire night. If the child has other like issues or social challenges, sometimes we can make the case for 2 caregivers to also be present, but definitely need one overnight.
It's over 18 months old, they can sleep alone.
Years, sorry.
Sorry?
Up to 18 years of age, we should have one caregiver in the room. Yeah, so basically all children and adolescents need one caregiver in the room. Yes.
I'd like to go back to the study that compared the high flow nasal cannula with CPAP and how they work. Yeah, that one. Did you have the average for range of CPAP pressures there, or is it just CPAP in general? And the reason why I ask is I think earlier you had said that the high flow nasal cannula is roughly like 4 to 7 centimeters of blood pressure compared to CPAP.
Right.
So are we looking at, you know, these apneas that are resolved in that pressure range, or like is CPAP going to 12, 13, 14 and the high flow is still fixing that severity back?
Yeah, I guess that's a really good question. So in this study, the highest CPAP pressure that they went to was 12 centimeters of water. And so that's a really good question, because if you're going up to 12 centimeters of water, there might have been theoretically some patients that would not be covered with the high flow being limited to 4 to 7. And I guess that's where the other mechanisms of high flow beyond just the generation of positive pressure probably lend some improvement in terms of reducing your anatomic dead space, your washout, comfort, secretion management. So that's a very, very good point. Yes, Mark.
For the high flow nasal cannula therapy.
Yeah.
So what's the difference between the pediatric cannula and the adult cannula?
It's the diameter.
Does that mean?
It's the diameter, and because of the diameter, it limits the upper range of the flow rates that you can achieve. So pediatric would typically cut off at 25 liters per minute, and adult up to 60 liters per minute because of the diameter.
So for that machine is different from the CPAP machine or same?
It's different than a CPAP machine.
So we control starting by control the volume of the air, not the pressure.
Correct. So you're controlling the flow rate, and by that we're indirectly assuming the pressure that would. I guess because the studies have been done on transesophageal pressures to see what kind of relation there is between them. But you're correct. We're not setting a pressure; we're setting a flow rate.
I have a quick question. It's Hamad. Thanks for the really, really interesting talk. I just have 2 questions. One is the patients you guys do have at Sick Kids on high flow, how is it funded? And 2, selfishly, do you know if the application that you guys have submitted for coverage includes for adult patients as well?
So the first part of that question, how is it funded? I think there's a lot of creative ways that we try to do this. We try to go through, I guess, patient amenities and see if there's any sort of leeway with that with our social workers, but not very successful in going through that route. We also then, during the admission, ask them to appeal to their insurance providers and see if some insurance providers will pay for their coverage. I'd say my experience is probably 50-50, but maybe Sunny knows more about that. But and then I've also seen, I had a patient earlier this week who were self-funded. And so I think half of them are probably, in my experience, half of them are probably self-funded, and half of them are probably covered through insurance. And I've seen maybe a couple that were covered through the hospital amenities, but I don't know, Sunny, similar experience?
Yeah.
Yeah, so Sunny's got similar experience with it. And then to answer the second portion of your question, it does not include adult patients. So the application we submitted, Dr. Min submitted and leading is all pediatric.
How much is it?
How much is?
How much you said they have to be self-funded?
Oh yeah. So it typically there's the 2 options that we discussed where if you're purchasing right here, so somewhere between $3,000 to $4,000 upfront if you're purchasing, and then $300 per month. Yeah, not insignificant. And then Dr. Mena.
So we have a comment from online that high flow is 100% covered in Saskatchewan.
Oh, great.
I didn't know. And I guess my question to you was, if you sort of alluded to it through your talk, but sort of thought mechanisms around mechanism of action of how it helps both obstructive sleep apnea and if there's any role in central sleep apnea as well.
Yeah, so the obstructive, I guess the comment about Saskatchewan, that's great, because I think that's basically what we should all be achieving for. So happy to hear that's covered there. And then the mechanisms, I think we talked a little bit about that, but it was the generation of positive airway pressure and improving your CO2 washout and reducing your anatomic dead space. And then I'll just touch more on the positive airway pressure. I mean, what we discussed is you're breathing against this high flow rates on expiration, and then again sort of helps to stent the airway and provides a stent in that fashion. And then, sorry, what was the second portion of the question?
If there's any role in central sleep.
Oh, central sleep. So no, there is not a role in central sleep apnea. Actually, it's actually the opposite. I forgot where I put the contraindications, but central sleep apnea would actually be one of the contraindications for using high flow therapy. And there's two, I think there's three, but I forgot the third. But there's two mechanisms of why it helps in central sleep apnea. Sorry, why it doesn't help with central sleep apnea. Actually makes things worse. It basically increases the risk of emergent central events. And so the first mechanism of that is through the washout of CO2. And you can get that CO2 be washed out below your anaerobic threshold and causing the emergence of central events. And secondly, you can get central events through the Herring-Brewer reflex, where your body's basically, or I guess your chest wall muscles are going to limit your inspiration beyond a certain pressure. And if high flow is pushing you beyond that pressure, then you're gonna cause some central events. So it's actually one of the relative contraindications for using, but it's one of the relative contraindications for using high flow therapy.
We do have a bit of time, so if there's questions for any of our speakers from the previous talks as well, you feel free to ask. Maybe we'll have them come up to the front here.
Yeah, I have a question about for BiPAP titration, ST mode. So the difference between the IPAP, PPAP, what is the maximum difference we can use?
Like the delta?
No, the IPAP,
Yeah.
The EPAP, the difference in the BiPAP titration
Should not be less than 4 and not more than 10.
Yeah.
That's average. But there's a backup rate. We can ask them. The part is 12. Last time you used ST, and we were able to control center. The patient was very happy. Doctor was also happy. All the centers became healthy breath. And granted a titration. He phoned me at night. Hey, when I did ST and changed the backup rate, all the centers became healthy breath. Then I said, we cannot change ourselves. I phoned the doctor, gave the permission. He said, go for it. Then we found out after scoring, patient was happy and the doctor was happy. Of course, then it is a Chinese doctor and he always tries. He's very fond of BiPAP ST.
There's a question online if there's any downsides to using high flow, if there's any negatives in the patients who've seen using it.
I don't think so. I think the main thing is with since the emergence of central events, and that was actually one of the studies that I mentioned. It actually occurred in I think 1 or 2 of the patients. But apart from that, I think from the funding aspects would probably be the biggest. And if there's any significant risk of aspiration, that still remains, although it might be a little bit less of a risk than using PAP therapy. Sending that comment about that question about the greatest difference between inspiration and expiratory pressures for BiPAP. I think I've seen it going beyond 10 as well sometimes, right?
Yeah.
Yeah.
I had to do that. So like on a case by case, you might exceed that. I don't know if 10 is what's recommended in the AF.
Sorry, we were just saying on
the question that Grant was asking about the maximum delta on bilevel being 10, certainly on a case by case, you might need to exceed that difference depending on the patient needs. So it really depends on the goals of therapy and what the patient requires.
That means we can include.
Yeah, if you need to.
Protocol in the lab is we have to get the permission of our doctor, medical director at night. They always return our call when we call them at night.
Yeah, and that 4 and 10, I think your quoting is coming from the ASM titration for obstructive sleep apnea. Generally, for OSA, you wouldn't need a large delta. And when I'm thinking about the patients that we're using a large delta, it's patients where you've got hypoventilation for some other reason where you might need a larger delta.
While you have the mic, Dr. Bola, for kids who do not manage CPAP very well, in your clinic, you might see failure of CPAP, or after adenotonsillectomy, after CPAP, they still are not able to be treated. What's your approach, including the kind of sick kids? Maybe you want to talk about the DREAMS clinic a little bit.
Sure. So the question was about how do you manage refractory OSA, either to CPAP or in the context of CPAP noncompliance, someone who has severe OSA. And so there's when we looked at those treatment options, one of the boxes that we went into was advanced surgical options. And so we have a multidisciplinary clinic at SickKids where we have ENT and sleep medicine. Sometimes dentistry is there, and plastic surgery to look at the specific patient's risk factors for OSA. And so that's when Cine MRI that we had talked about and DICE, drug-induced sleep endoscopy, come into play. And you can identify particular sites for intervention to reduce the degree of obstruction. And so that's when you might target the tongue, the size of the tongue falling back, the jaw, and the midface. So that's generally where you're going to go if you are either intolerant to CPAP or CPAP / bilevel is just not cutting it, that's very unusual.
And you mentioned DICE. I know SickKids doesn't use it as much. Could you comment on